Hi. Hello, everybody. Welcome to Knock Knock Hi with the Glockenfluckens.
We need to get like an echo.
Is like the wrestling announcer, right?
Yeah.
Right? I am Dr. Glockenflucken, Will Flannery.
I'm Lady Glockenflecken, Kristen Flannery.
We're talking mitochondria today.
We are.
So what do you remember about mitochondria?
I remember ATP and ATPase.
ATP?
ATPase? Yeah?
There's
It's been a long time.
transporters, there's electrons, and they're being transported, and there's lots of transport, and people are transporting.
There's a lot of that to make energy.
To make energy because it is the powerhouse of the cell.
Yeah.
And I've learned a lot in our conversation today.
I think I learned more about mitochondria today than I did in any class ever.
We talked to Dr. Heather Gatcombe. So Dr. Heather Gatcombe is a clinical radiation oncologist. We talked a bit about that.
That's right.
A character I do not have in my content. And so I got some ideas from her.
Mm-hmm.
Not just circling things on a screen.
Yeah.
We learned that. So,
right.
It's a very challenging job.
It is. There's a lot that goes into it.
Oh, and got to be so smart.
Yeah.
Honestly,
yeah.
All these years I've been saying, nephrologists are the smartest doctors in the hospital. Actually, I vacillate between nephrologists, rheumatologists.
Yeah. Infectious disease.
That's like the triumvirate, I think, of just like really insanely smart people that have medical jobs.
Okay.
I might have to put radiation oncology in there.
Yeah.
Some of the things she was describing, I'm like, she has to know a ton of like medical physics.
Right. I didn't even know that was a thing.
And on like cancer biology and like basic science stuff. Anyway, just listen to it. It's really, really amazing. But
she's not just here in that capacity today.
No, she talked about her son who has a mitochondrial disorder. And so we talked about their journey with mitochondrial disease, all the clinical manifestations, the challenges, the treatments, and the how it's affected them as a family. And so if
it
you're
was really, really, really interesting.
If you're if you know somebody with chronic disease or you yourself have chronic disease, like I think this will really resonate.
You see people with unexplained symptoms or chronic disease.
Yes, absolutely. Please. So stay tuned for that. Should we jump into it?
Let's do.
All right, here we go. Dr. Heather Gatcombe. Hey, Kristen, remember how you love eyelid mites now?
Mm-hmm. Sure.
Yeah. Well, there's a lot of confusion out there. I want to clear something up.
Okay.
All right. People think they can get eyelid mites from dogs and cats.
Can they?
No. These particular Demodex mites are specific to humans.
Okay.
So spread from dogs and cats is not expected. That's a myth.
Can't get them from cuddling our poodle.
No. Demodex mites that cause blepharitis live on humans. Most adults already have them. They just usually don't cause problems. It's when they overgrow that they can lead to itchy, red, irritated eyelids, those little collarettes.
Mm-hmm, the crusties at the base of the eyelashes.
Right.
And the good news is there's a prescription eye drop available for Demodex blepharitis.
That is great news. To learn more about eyelid health and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals.
Hey, teacher besties, I'm Andrea Forcum, and I am so excited to share with you that my book, They Never Taught Us That, is available right now. It is everything an experienced or first-year teacher needs to manage the chaos of the modern classroom, including some anecdotes to make you feel a little bit better. Because if there is a way that you can screw up, I've probably done it. It also has advice on how to build trust with families, how to manage grading and lesson plans and IEPs and everything else that they never went over in your teacher prep program. They Never Taught Us That is available everywhere right now.
All right, we are here with Dr. Heather Gatcombe. Heather, thank you so much for joining us.
Thank you so much for having me.
There's several reasons that I am so excited about this. Number one, we're talking to a radiation oncologist, and I have not spoken with many of you, many people in your field. In fact, I get reminded of it pretty regularly that I have very little content about radiation oncology. So I'm going to rely on you today.
It's kind of ironic, too, given that you're a cancer survivor, twice, no less.
But I never
But
received.
you never had to
I
get
never had radiation.
Yeah.
And so I hope you're ready to give me all the details and help me flesh out a nice radiation oncologist character.
Ooh, I'm happy to do that.
Can I start with what I know about radiation oncology, which is going
Sure.
to be
Let's go in.
very embarrassing, I think, on my end. I understand there is a fair amount of drawing circles and ovals around things.
It's a bit more intricate than that. So we
I
are
figured. That's why I'm asking.
Yeah, so we're planning radiation treatment for cancer patients. So we're doing fusions of MRI scans and PET scans. And so we want to make sure we're delineating the tumor accurately. But yes, there is a lot of contouring involved.
Oh, contouring. Okay. I'm glad that's helpful to know.
Yeah. That's similar to like makeup.
Yeah, Rob, our producer, write that down. All right, contouring. That's if I make a video, that's how I need to refer to it. Not drawing circles. That'll be how the idiotic administrator references it. All right. So what got you into radiation oncology? Like how does that happen? Because I remember I don't even think I had any exposure to this field, like whatsoever in med school. So how do people find it?
Yeah, so I knew by my second year that I wanted to do oncology. So I was in the old system. I finished med school 22 years ago. So the first 2 years were in a classroom, the next 2 years were clinical. So by the end of my second year, I decided I was going to be some type of cancer doctor. So when rotations came, I signed up for medical oncology and pediatric oncology and surgical oncology. And I found out about radiation oncology through those rotations. And then it was just a perfect fit because I liked anatomy. I liked diagnostic radiology, but I like interacting with people and having conversations. And it gave me day-to-day variety.
Yeah. And what are those conversations like with the patient? Just give us like a little snapshot of like, because you have a very complicated field. Like it's, I imagine there's lots of physics involved. There's lots, obviously you probably don't get into like electrons and protons. Maybe you do. I don't know. Like hardcore
We do.
chemistry. You do? All right. Well, teach us a little bit. Like, how do you approach the topic of radiation to a patient?
Yeah. And as part of our residency, we do have to be certified in both cancer biology and in medical physics. So we take a physics and cancer biology before we could even take our written clinicals, before we can then take our orals, which are also intimidating because you're with the experts in the field. So for pediatric oncology, you're meeting with the renowned experts in who teach children. It's the same for breast and lung and sarcoma and so forth.
So you're like answering questions from like a physicist?
She's real smart. This is what I'm taking from it.
I've always known that radiation oncologists are crazy smart. Like,
I'm learning all of this for the first time. I have no knowledge of any of this, so I'm very impressed.
Wow, that would be intimidating.
I didn't even know there was such a thing as medical physics. Is that common?
Tell us about medical physics.
Yeah, so we have a lot. We have a lot of support. We have a large group. We have a large team in radiation oncology. So we have medical physicists to make sure all our plans are safe. We have a lot of quality checks in radiation oncology, obviously. So when you come in, a patient sees our front desk staff first. They'll see nursing. They'll see the radiation oncologist. But our therapists are who is going to bring them back to do the daily treatments. And our dosimetrists plan the radiation. There's a lot of people behind the scenes in the basement in radiation oncology.
Oh man. And so what does your like preparation look like for deciding how to deliver this radiation care to a patient? I imagine obviously you're going to talk to the patient about it, but like take us into like the kind of the planning process and going from, okay, this patient's chart comes across your screen and then all the way to like the delivery of care. But you can like, obviously we only have like an hour. So shorten it for us, but give us an idea.
Okay. I will say just up front, we are part of a multidisciplinary cancer team. So even before I
Mm.
see a patient, often the surgeon's calling me, the medical oncologist. So,
Okay.
and every plan's individualized. So, if I'm seeing a patient with breast cancer, I'm going over their pathology report. I'm going over all their imaging, and I basically go through everything with the patient. We're lucky we're one of the few fields I have an hour with each consult, so I have time to kinda
Wow.
dive a little
Oh, that's
deeper.
amazing.
Yeah. I mean, good, rightly so. I am
Well,
happy to hear that because it's a touchy not touchy, it's a very difficult topic.
right. Yeah, it's scary. I mean, it probably sounds
Yeah.
scary to a lot of people too.
Right, difficult, cognitively, but also emotionally, like, these are
Yeah.
conversations that probably need that time.
Yeah, I mean, patients are overwhelmed. I mean,
Yeah.
it's so scary as you know, to have a cancer diagnosis, and even being in the medical field, it's so hard to figure out how to navigate the system. And so part of that is just making sure they understand what we're doing and why, and making sure they have all the support services they need. Do they need to see a lymphedema therapist? Do they need nutrition? We work with supportive oncology and psycho-oncology, just
Mm.
making sure they have everything they need.
Well, we've talked a lot about your job and at Emory and all the work you do, but that's just one part of your very busy life. And another thing that we're excited to talk to you about is just the journey you've had with your child and mitochondrial disease. So I want to kind of switch gears a little bit and can you just I'll let you take it and just tell us about that part of your life.
Yeah, so, my son, he had a healthy childhood. He met all of his milestones, but in the 2nd grade, I received a call that they thought he had a stroke.
Ugh.
His hand went numb, and his teacher noticed he had a facial droop and couldn't move half of his body. So they actually had to physically carry him to the nurse's office. They called 911. By the time EMS came, he was actually back to his normal self.
Hmm.
So I met them in the emergency room.
Where in your career was like are you practicing at this point? Are you
So
in
I was
training?
done
Well,
with
yeah.
residency. I was in private practice in the community. So I
Mhm,
was
okay.
actually working 45 minutes away.
Mm.
So that was
Ugh.
a very difficult drive. Um, and when I got to the ER, he looked like his normal self, and I just couldn't comprehend what had happened in this. I can't remember if it was 7 or 8. But when the neurologist met with us, they said, this is probably just a hemiplegic migraine because his lab work was negative, his urine was negative, he didn't have an elevated lactate.
Mm,
They eventually got an LP, and his CSF was normal. And it wasn't until they ordered a stroke protocol MRI that they said, this is probable mitochondrial disease because he had
mm,
evidence of swelling in the basal ganglia. There was some T2 and flare abnormalities. And once they ruled out, toxic exposures like carbon monoxide poisoning or Wilson's disease, we were left with a diagnosis of probable mitochondrial disease that we had for a while. They actually ordered genetic testing. It took 3 months to come back, and it was negative. So genetic testing is the gold standard to diagnose mitochondrial disease, but his mitochondrial DNA was normal, the nuclear DNA was fine, but we were still told, "This is what we think."
Is
Mhm.
that genetic testing, can that be done just with a blood test, or is it like a bone marrow, or, like, how does that work?
Yeah, there's different ways to do it. It's usually a cheek swab,
Oh, okay. Even easier. Alright.
Yeah.
There you go.
even easier.
What the just up until just this point in your story, I've already been on, like, such an emotional roller coaster. Like,
I'm sorry.
no, no, no,
That's why we're talking about
yes,
this.
exactly. This is one of the big things is I want people to understand what it feels like to be a patient and to be a co-survivor of some of these really scary things. And so just as a mom, I was just connecting with gosh, what that must have felt like to get that phone call and then 45 minutes to get to your kid. That's an eternity in a situation like that. And then 3 months to have to wait for answers. Like, just all of that is just excruciating. And we haven't even gotten to like
Mhm.
the medical
Mhm.
stuff yet. Yeah.
Yeah. And were you I mean, I wanna explore that actually a little bit before we get into the medical stuff because, like, I'll just compare it to my experience and, when I had my cardiac arrest and trying to, like, go back to work after that was really challenging, and so and I can't imagine, like, what that must have been like to have to work while in those 3 months when
Yeah.
there's so much uncertainty. Um, did you did you have trouble? Were you able to compartmentalize or, like, how did you get through that?
Yeah. I mean, that was pretty much the changing that was a turning point in our lives. I mean, I had so much fear after that
Mhm.
because we don't know what brought it on, and we really didn't know why it happened, and we didn't know when it was gonna happen again, and he was terrified because
Oh, yeah.
it was so scary, and I didn't have any information to share to kinda explain that for him to him.
Mhm.
And so you get this diagnosis of mitochondrial disease. But first of all, what so there's tell people about mitochondrial. You probably know. I know a little bit
Yeah.
because there is some ophthalmology overlap.
Mhm.
And which you better believe we're getting into some ophthalmology stuff here. At least I hope so. Anyway, what it's an uncommon thing, and
Yeah,
so
I'm not familiar with it at all.
yeah,
So, for
would you
people that
mind
don't know.
telling people a little bit about this like kind of spectrum of disorders?
Yeah, so I actually never learned about mitochondrial disease in medical school. Um, and even now what the young doctors are learning is kind of limited. And it's because it's a newer
Mhm.
field. We've only known about mitochondrial disease for the past few decades. But it is a mutation. So a primary mitochondrial disease is a mutation either in the mitochondrial DNA or your nuclear DNA. And when your mitochondria aren't functioning well, they have trouble creating energy because your mitochondria transform the nutrients in the food that you eat and the oxygen you breathe and convert it into energy. So this is essentially an energy problem, and it can present differently in different patients.
Yeah. How rare is this? Do you have an idea?
So, yeah, we currently know it occurs in about 1 in 4,000 patients, but we actually think the number may be a bit higher due to the number of undiagnosed patients in the community.
So that must mean there's a pretty wide spectrum of severity, I imagine,
Correct,
right?
correct. Yes.
Okay. And so as you're learning all this with your son, what I guess what were the symptoms? What were so there was the initial episode and then like for
Mhm.
that 3 months, that first year, we'll say, what were what was he experiencing? What were you both experiencing as a family?
So, after that episode, he started having, those were later called metabolic strokes. He was having metabolic strokes 2 to 3 times a year. And then he developed sensory neural hearing loss. So he just happened to fail his 8-year-old hearing check that we didn't even notice on conversational talk that
Mhm.
his
Mhm.
hearing was going. But that actually made his neurologist even more suspicious that this was mitochondrial disease because hearing loss is very common, in addition to eye issues that you may be familiar with.
Yeah, did any
Um,
of that come up at all?
he does not actually he may have a little bit of mild nystagmus, but it is
Mhm.
you don't see it, um, unless you're testing for it.
Yeah, there's different, syndromes like the MELAS and Kernsayer, and I'm not going to bore our audience with, like, all the the clinical manifestations of all of these,
In
but
ophthalmology
so
specifically.
you had how long do you have, like, a name for the diagnosis, or is this just kinda might? Because not everybody fits into a particular, you know,
This kind of
constellation
is reminding me of
syndrome.
EDS, where there's, like, a whole bunch that is just such a broad term that can mean so many things.
Yeah, so, he does not fit into one of the typical, like, syndromes like MELAS.
Mhm.
Um, so, initially before we were able to do, rapid genetic testing where we had the ability to test for thousands of genes, patients were put into these clinical syndromes like MELAS and Leber's. And the diagnosis was by getting blood work and doing muscle biopsies. But now with genetic testing, it's actually the genetic mutation, um,
Mm.
which is what causes each type of mitochondrial disease. So when we actually did not get a diagnosis until 5 years after his initial symptoms, they kept rerunning genetic testing every 18 months or so, but it was negative. And so after 3 years of this and getting second opinions at multiple institutions in the country, we actually went and did a muscle biopsy just to have some answers.
Oh,
And they did find that he had less mitochondria than he should have, and he did have some dysfunction. Um,
okay.
it wasn't working as well as it should. And then a year later, we came back and he had a variant of unknown significance in his nuclear DNA. But they didn't know what it meant because there was nothing in the literature. And then the following year, we came back and there was a case series of patients with the same mutation with similar symptoms. And then
Oh,
we finally had an answer.
yeah. Wow, what
Uh,
a
welcome to
just
the,
yeah, we're
mutation
in the
of
same
unknown
boat.
significance club. That was my that was my genetic testing
Yeah, for
too,
the cardiac arrest.
and hearing you say this is like a sign because I also at a recent I went to a Heart Rhythm Society meeting, and I had an electrophysiologist come up to me and was like, you should get, repeat genetic testing now that it's been, like,
Yeah,
6
Hmm.
years."
I never would think to do that because, like, your genes are your genes, but I guess it's the technology develops, is that the
E
reason?
I think so, yeah, and also, I don't know, just, they just know more, and
Yeah.
you never know when, like, a pattern is going to develop around certain things, and so, I don't know, I guess,
Mm,
you know.
Yeah, usually they say recheck every 18 months or so, but it's also you need to meet with the medical geneticist to see what testing they did because they're
Mhm.
finding new mutations.
Right.
And even though they did whole exome testing on my son, so they were testing for all the mutations, but we didn't have anything in the literature that showed it was a pathogenic mutation until
mhm,
someone wrote up a case series.
Interesting.
right.
Um, was your son part of the case series? Or is that
No, that's how they
Not that
found
oh,
him.
that's how
one.
they found it, right, that's
That's
how they found it.
yeah,
Yeah.
not that one, but our geneticist is actually collaborating, with others, and my son is in that series, and actually 3 out of the 4 patients that they're about to publish this, 3 out of 4 of them have had heart transplants, like my son.
So I wanna talk about that. Let's take a quick break, and then I wanna come back and discuss more of the dive into, like, some of the clinical manifestations of this disease. Alright, we're back with Dr. Gatcombe. So, Heather, uh, you mentioned a few of the clinical manifestations already, and I'm sure it's just a laundry list of possible things that could happen because this is, your mitochondrial DNA that's in every single cell. So you mentioned metabolic stroke. Can you explain that to us? I mean, me
Explain
too.
it like you're an ophthalmologist.
Explain like you're trying to teach an ophthalmologist about a metabolic strokes.
So again, I had never heard of one until it was in my
Yeah.
son's diagnosis. So a metabolic stroke is different than a vascular stroke. This is essentially an energy problem. So a patient can have a neurological event that may or may not be associated with seizures. But when you order a brain MRI, it's not in a typical vascular finding.
Mm.
And sometimes you can see evidence of swelling, so T2 or flare abnormality in the deep gray matter of the brain, like they found
Oh, the
in my
basal gang. Yeah.
child
Yeah.
in the
Okay.
basal ganglia. And it's treated very differently, again, because this is not due to a bleed or a clot. Um, that part of the brain does not have enough energy to function and it shuts down. So
Mm,
it can present very differently in different
But it's
people.
not like a stroke where you lose the tissue, like the tissue dies. It can come back if there's the energy stores are replenished or not.
That's a very, very good question. And that very first episode my son had, a geneticist sat us down and said, if you don't get him to the ICU in time, his symptoms may not be reversible. And if I look back, each metabolic stroke, it took longer for him to recover. So the first one was less than 30 or 40 minutes. The next one, he didn't recover for almost days. And he hasn't luckily had one in about 2 or 3 years, but the last one, he lost the ability to move his left side. He couldn't see on the left side. So once he gained
Mm.
strength, he was walking into walls on the left side and couldn't see the left side of the page. So after his discharge, he was doing rehab for 2 weeks, daily rehab, and then he did PT for 2 years. So if it's not treated appropriately, you can have permanent neurologic consequences.
Mm.
What is that treatment? Let's talk about that.
So again, this is an energy problem. So we need to make sure patients are getting fluids and they're getting dextrose-containing fluids. Usually they use D10, and IV arginine is the treatment for metabolic stroke. So it's an amino acid. It increases nitric oxide in the brain. So it's a vasodilator. And so that's been shown to help in patients with metabolic strokes, like with MELAS.
Interesting.
My son
Yeah.
doesn't have MELAS because he doesn't have that particular mutation. He doesn't have a lactate spike, but he's treated like a MELAS patient.
Gotcha.
And then finding the cause of why they had the metabolic stroke. Was it because of a fever? Treat fevers aggressively, treat any infections aggressively. It's very important to keep these patients out of a catabolic state. These patients often can't fast. They're prone to have a metabolic stroke or metabolic crisis if they're dehydrated. Any time of stress, so
Interesting.
surgery, certain anesthetics or medications can precipitate it too.
That's fascinating.
Yeah.
So, sugar water, that's the dextrose, just in case,
Yeah.
So that's like putting,
I figured it was some kind of sugar, but
glucose,
yeah.
in water, in IV fluids,
Uh-huh.
and,
Which makes sense if it's an energy
yeah, yeah.
issue.
And so
Yeah.
this must thinking a along that line then, I'm sure it's changed your, like, day-to-day
Oh
life,
gosh,
and
yeah.
well, so I have
Oh,
2
yes.
questions. One, I wanna talk about that, like, 'cause I'm sure there's so like, activity restrictions and things probably constantly, like, snacking, right? I imagine, like, there's lots of that, but what, is it the treatment you already described, is that a can that be a preventative measure
Yeah,
or
so if you're having an active metabolic stroke, you usually want to start IV arginine within 3 hours of having symptoms. So they give a bolus and then they offer IV arginine until the symptoms resolve. And then he's also on oral arginine to prevent a metabolic
okay.
stroke.
Okay.
What does life look like? Since what now that you have a diagnosis and what could potentially precipitate any clinical manifestations, uh, what are the things you avoid? What are you making sure you do? And
Yeah. So, I mean, it was developing a new normal for our family. So we always had to be careful in heat, make sure he was never fasting or dehydrated, make sure he goes to bed on time, which is becoming more of an issue
oh my
since he's
God,
17.
Yeah. Yeah.
and you're in Atlanta.
Yeah, it's hot.
We were in Atlanta. It is hot. It is hot in the
Oh my
summer. So
God,
always having access to air conditioning or a
Mhm.
pool. Um, I mean, it
yeah.
changed the way we travel and
Sure.
where we go. Um,
Did you think about going to like the Yukon territory in Canada for 10 years
I
or
have
so?
thought about it. I mean, it changes where we vacation
Yeah,
and
Sure.
where and when we
sure.
see family. Um, when we go, yeah, exactly, exactly.
Wow. What about like sports and activities and you know?
Yes, so he was allowed to continue playing soccer. He was an active kid, and we avoided baseball. It's the hottest months of the year.
Yeah.
That's
Swimming
right.
was allowed.
Okay.
But he was never allowed a head in soccer because any head trauma could
Mm,
also
Oh.
precipitate a metabolic stroke.
Oh, wow. Okay.
interesting.
So I imagine just like having an increased heart rate and aerobic exercise, like I mean, that's also a metabolic stress, right?
That is correct. That is correct. And actually, for patients with Mito who are able to exercise, we recommend both aerobic and resistance training, because that can actually increase the number of mitochondria and improve oxidative phosphorylation. But I mean, you have to listen to your body.
Right.
Yeah.
Can he I guess, are there signs, like, as he's lived with this for years now, like, can he tell when, "Oh, I need to calm my body down," or, "I need to eat something," or
Yes. Yeah, he knows his body really well. And if he's about to have a metabolic stroke, he will tell us. He knows. He kind of has a prodrome, and he'll say, "Mom, I'm about to have an episode." And for him, it tends to follow predictable numbness, weakness. He develops an aphasia and altered mental status. I mean, other patients
Mhm.
may present differently, but for
Mhm.
him, that's how it usually presents. He always has a water bottle on him. He always has snacks. We're making sure he's taking his medications regularly. He's on a special individualized Mito cocktail that most Mito patients are on.
Mm.
So when they did that muscle biopsy, do you remember the Krebs cycle from med school?
Do I remember the Krebs cycle? Of course I don't remember
He's
the
got
Krebs
it
cycle.
tattooed on his back.
You know, I've gotten a lot of jokes out of the Krebs cycle over the years. So in that respect, I appreciate the Krebs cycle, but, yeah, this is I mean, you actually kinda have to, like, know the Krebs cycle. This is like
This is the first instance I've
this
ever heard of the Krebs cycle being useful.
this is amazing. I didn't even like, you're saying that I'm just now putting this together. Oh my god,
Yeah.
this is an application for the Krebs cycle, so please,
It
take it away.
is. It is. So when they did his muscle biopsy, they do functional testing. So they saw what complexes weren't working as well, like complex 4, complex 5. And so they pushed more cofactors in to kind of push the process through. So he's on ubiquinol and he's a lot of antioxidants and vitamins. And in addition to the arginine and his other meds. And actually, once he started that cocktail, he did not have another metabolic stroke for about 2 years
Hmm.
until he developed his heart issues.
Yeah, so let's dive into the heart issues, but real quick actually, and we're talking about the Krebs cycle, just for
Can't let it go.
no, no,
Gotta go back. Gotta go
well,
back.
here's the deal. Like, I did a video, a skit once where it was, like, med students sitting around a table, and they were all, like, complaining, like, having to, like, "This is so stupid. Why are we learning about the Krebs cycle? Like, I'm never gonna use this," all that, go back and forth, and then they get up and leave, and sitting at the table behind them with a really sad look on his face eating his sandwich for lunch is a medical geneticist, and, like, a tear just kinda rolls down this cheek, and so I guess there's some truth to that, right? Because it's probably the medical geneticists out there that are actually tuned into the Krebs cycle and need to know a thing or two.
Right.
I don't know.
Yeah,
So
exactly. Yeah.
Does because I was a former life, I was a brain nerd. So does this might be a stupid question, but just like physical activity is taxing, is like cognitive activity also uses the brain uses a lot of energy. So does he have to be careful about that stuff too? And can he use it to get out of his SATs?
He actually just took his SATs
Oh,
on
nice.
Saturday. But yeah, I mean, he will tell us if he needs a break. Like he is very
Okay.
aware and attuned to his body, both physically and mentally. And there'll be times where we'll receive a call saying, I need a nap. Like he
Yeah.
just needs to rest more than other kids.
it's probably a bad idea for him to try to learn the Krebs cycle. I'd imagine that would
I don't
that
know. He might know it better than most. Who
probably
knows?
not, yeah, not be that.
Not
I mean,
yet. Not yet. We haven't
not
gone there.
no, don't. It doesn't even need to think about alpha ketoglutarase or whatever the heck. All right, so let's talk about the heart issues. So how did that start, and how did that initially manifest?
Yeah, so it was in the middle of the pandemic. So it was in January of 2021
Perfect
where
timing.
Yeah,
he just
just what
started
you need.
perfect timing. Where he started feeling more tired and the pandemic was I mean, he had been doing virtual school for about 10 months. So he went from walking a mile to school, walking a mile home, doing academy soccer 2 to 3 times a week to just kind of sitting at home. So at first I was like, "Oh, we can't bike up this hill anymore. Maybe, we haven't been exercising as much."
Mhm.
And then it progressed to GI symptoms where he just had vague nausea and upset stomach. And then he started throwing up.
Mm.
And then he started having throat clearing towards the
Mhm.
end, which I did not realize at the time is actually a symptom of heart failure when there's increased fluid in the lungs.
Oh.
Um,
Whoa. I'm learning so much
whoa.
today.
Yeah.
I had no
Yeah.
idea.
I'm glad you didn't know
Wow.
that either because
I
I
didn't
felt I was racked with guilt for 2 years. So,
No.
Oh, no.
So congestion in the lungs, and I guess that it would extend and
Up
you're
into
just
your throat.
yeah, you just like more swelling up there and you're just trying to oh, interesting. Wow. Okay. All right.
yeah. And my husband's a psychiatrist, so he thought he
Uh,
had
oh.
Tourette's. That
Oh.
wasn't
Oh, no.
helpful.
Just a little Tourette's detour here.
Anyway, so, well, you're not alone, and, I mentioned there's probably a lot of doctors listening who are also as surprised as I am. So,
See, this is so tricky because and I see a lot of parallels with you and your symptoms. It was very similar. Like when it's all things that can be explained away by just like what's going on in your
circumstances,
life,
yeah,
it's so hard to put it together that no, actually, there's a big problem here. And it does. I relate to the feeling of like, oh, I should have seen that. I should have known. But there's so many simpler explanations. So
right.
why would you jump to, oh, it's heart disease or oh, it's cancer or whatever?
Oh, I was just going to say that these were COVID times, so all of his
Yeah.
visits were virtual, so no one listened to him. Everyone thought he had COVID, and it was so hard to
Mm.
get a PCR test at the time. So it wasn't until we took him to the ER to get a PCR test and get some fluids that we found out.
And what did they find what was on that testing?
Well, he actually did not have COVID, but he was in acute heart
You're talking
failure
about the
with
COVID testing. I see,
cardiomyopathy.
I see, yeah.
Yeah.
Yeah. So they got a COVID test. It was negative, and what let them know that it was cardiomyopathy?
So when he came in and they listened to his heart for the first time in 10 months since his last doctor's appointment, that's when, I mean, they probably heard a murmur. And then
Yeah.
by that time, if you look at pictures of him throughout the day, he started developing more facial swelling.
Mm.
It's like angioedema kinda
Hmm.
situation. And they may have on that physical exam, they may have heard the legendary, S3 or S4. Do you remember those?
I remember those,
Do
but
you
I don't know if that's what they heard at that time.
No, I don't
He's
know
just
either.
trying to show off that he
I'm just
knows
like,
one thing
well,
about it.
these are things like we're hearing about things that, you're not really ever sure actually exist in med
Yeah.
school. Like these extra heart sounds. Are you really?
Hmm.
Are you
Right.
sure they're real? The Krebs cycle, does that really exist? I don't know. I mean, clearly it does. And so anyway, um, and so from that point, you have the diagnosis like, okay, there's a cardiomyopathy here. And then how long before like the talk of heart transplantation came in?
Yeah, he crashed really quickly. So he deteriorated as soon as he came to the ER. They found a bed for him in the cardiac ICU. He was brought up straight to the cardiac ICU, and then that's when he started developing more facial swelling, and
Mm.
he it was bad from the beginning. Like he was in severe heart failure when by the time he was admitted to the cardiac ICU. And I actually went home because I had a baby at the time, and I went home to put the baby to bed. And my husband called and said, "You need to come back right now, because they're going to put him on ECMO." His status went down precipitously, and the doctor came in and said, "I see 3 heart rhythms incompatible with life. We need to put him on ECMO now, or we're going to be coding him in the middle of the night." And so it happened really quickly. It just
Oh my
Wow.
spiraled down.
god. And then that was so how from that point, transplant was on the table. It was like there was talk about it and getting on a list, I assume?
Yeah, so they did ECMO in the middle of the night within 10 hours of him being admitted. And then the next day when we came in, the next step was LVAD to put a left ventricular assist device in, and to see if that could reverse his symptoms. And then after that, he was on eh, there were multiple steps there, but the
Yeah.
path was towards transplant.
And an LVAD is, just so
Uh,
people know, it's basically like a external heart. Like it's like a external device that does the heart's job for it. Is that right? Is that fair to
Yeah, there's a pump
rudimentary,
in
but
the heart. Yeah, it's a continuous pump, but all the machinery is outside in like a
oh, okay.
little briefcase.
Uh-huh.
So after they have the LVAD, so he had been asleep for all of this and kind of woke up with a sternal incision. And with an LVAD, you have a drive line that's going to the batteries that's keeping the system going.
mm,
And then he had chest tubes and pacemakers. And it wasn't until 6 weeks after he had the LVAD that he was healthy enough to even be placed on the transplant list
Mm.
because he had developed multi-organ dysfunction at that point.
mm, gosh.
What an ordeal you guys have been through. Like, and for diseases like this, like mitochondrial disease, where they're not so common and,
Yeah.
it's a lot of different ways they can present. It's just so much uncertainty, right? And sometimes uncertainty is the hardest part because your mind can go to all the possibilities. And then once you actually have the exact thing you're dealing with, it's not like life is roses, but at least you know what you're dealing with and can like take action towards it. But man, it sounds like for a long time you guys were just multiple occasions throughout, 10 years or something. You guys have just been having to deal with a lot of that.
Right.
Does being a doctor in addition to, the mom of the patient, did that help make it worse? Anything unrelated?
I think it helps navigate the system, especially when we were
Mhm.
looking at getting second opinions and we were sharing his MRI with friends. But I mean, it still took us 5 years to get a diagnosis, even
Yeah.
with two MD parents and having connections. And that's no one's fault. It's just the science hadn't caught up yet.
Right.
And so for people in the community who don't have two MD parents, the process can take even longer. I mean, the average is about 10 years from the development of symptoms to diagnosis. It's shorter in children. They tend to progress with more severe symptoms. But in adults, I mean, it could sometimes take decades to get a diagnosis, especially when you're presenting with vague symptoms like
Yeah.
Right.
fatigue and GI issues.
Right.
What Yeah, I'm glad you asked that question because I wanted to know, what kind of barriers you've come across from the healthcare system standpoint that that maybe, other families going through this, can learn from.
I think the hardest thing when you have a rare disease is you're often the expert in the room of doctors, even if you don't have an MD. I mean,
Mhm.
you're trying to explain your child's rare
Yeah,
condition.
yeah.
And so we did have an episode where, after his heart transplant, he did great. Off, he was on a regular cardiac floor by about 4 days post transplant because he just recovered so well. But he wasn't eating well. And he actually asked for a feeding tube on day 4 because he was maybe getting some sugar water and he was maybe sipping some Gatorade, but he wasn't eating. And so he asked for a feeding tube and it was a weekend, so it wasn't our normal team. And they said, "Well, we'll ask the team about it." But it was kind of odd because what 12-year-old asked for a feeding tube?
Yeah.
Yeah,
Uh,
right.
and so I wish I'd pushed harder because he actually developed an aphasia about an hour after he asked. He lost the ability to speak. He had another metabolic
Mm.
stroke from
Ah,
fasting.
Yeah.
So often the barrier is, the medical community isn't familiar with how to take care of
right.
patients with mitochondrial disease.
So just, advocating for yourself and for your family.
Is there a, like, again, a very naive question, but is there any kind of specialist that does know more than the average person, or is it just like a collection here and there? There's a
Yes.
medical geneticist here, there's a, cardiac
Yeah, who's your point
something or other
person?
here. Yeah.
Yeah. So, I mean, we have an amazing medical geneticist in Atlanta. But there are so few metabolic and mitochondrial specialists in the country. We actually fly up to CHOP in Philadelphia. Most specialty centers see both kids and adults. This is a lifelong disease. There are only there's only 19 certified mitochondrial care network sites, and most of them are in the Northeast. There's a few on the West Coast, a sprinkling in the middle of the country, but none where we live in the Southeast. And that's a big issue, access to care for patients.
Yeah.
Not only to get the diagnosis, but once they have the diagnosis, getting the care they need.
Right.
Patients shouldn't need to start a GoFundMe page to fly across the country for care. And that's part of the reason I wanted to share his story with you today. We're trying to increase the number of mitochondrial specialists to take care of our patients and families. We actually lost a critical funding pathway last year that we had due to federal cuts. We lost one of our fellowship programs, the NAMDAC fellowship. And so the United Mitochondrial Disease Foundation of UMDF is trying to fill in this gap. We just developed some mini fellowships where residents and fellows can learn about mitochondrial disease in their existing program with
Oh, that's
grant
great.
funding to
Yeah.
see patients half a day a week and to learn from experts throughout the country and come to our national meeting. So had the funding to fund 2 fellows this year, but we're trying to expand that.
Whoa,
Yeah.
what an amazing, um, that's a what a great idea,
Yeah, that is a really
like a
innovative
little mini
approach.
fellowship. I love
Uh-huh.
that. Is this, like, internal medicine pathway that you're
It can
attracting, like,
be anyone
residents?
anyone PGY3 and above because,
Okay.
usually at this time, most mito specialists are geneticists or neurologists. But as you said
Okay.
earlier, there's mitochondria in every cell of your body, so it
Yeah.
can affect any organ. So we need specialists who are endocrinologists, gastroenterologists, pulmonary medicine, nephrology. And so anyone PGY3 and up is eligible.
Oh, that's
It seems like instead of memorizing the Krebs cycle, perhaps we learn some of these symptoms of what happens
well,
when the Krebs cycle goes wrong. Is that not
I mean,
happening?
theoretically, you do learn that, I don't know, maybe not.
It
I
just
actually
seems
don't
like
remem
more useful information to be able to
but
recognize it
it's
in patients
I mean,
than to just
yeah,
memorize
but
the
as
thing for the test.
as Heather's talking about, they can be, like, literally almost any symptom can be, mitochondrial disease.
Right, but I would imagine, like, within a particular system, because you're all specializing in different
Yeah,
systems, right?
yeah,
That there's, like, maybe a cluster of things that it tends to be, or, that at least in whatever your system is, you should know
yeah,
what the symptoms can look like, and then just be aware that that is a thing. Because if you're never seeing if that's not your area, you're probably not thinking about it. And there are times when it is a zebra, not a horse, right? So if you don't know what to look for to recognize the zebras, then you're gonna miss every single one of them. No? I know I'm outside of the
yeah.
systems. This is probably
No,
overly
no.
simplistic, but
No, you're absolutely
Yeah,
right.
you're
You're
right.
absolutely right. Yeah. So if you're a neurologist and you're seeing someone with stroke like episodes where you're having a neurologic event, you get an MRI, it's not in a vascular pattern, there's changes in the basal ganglia or other deep gray matter. That is very suspicious for mitochondrial disease. For ophtho, if you're seeing retinopathy with pigmentation,
Yep,
you mentioned CPEO or
there's
LHON.
yep, chronic progressive external ophthalmoplegia, which is you just have just slowing of the eye movements and restriction of movement in different gazes, and in different disorders, you can get external ophthalmoplegia for several different disorders, but, I've seen patients where their eyes are frozen. They just have no movement whatsoever. And so that's, like you said, with pigmentary retinopathy, optic neuropathy, so neurologic signs, that you see through an eye exam.
so it
Yeah.
does. It sounds like there's these
Well, oh,
patterns that
there's
if you know
yeah,
to look for them, you
right.
could find.
So yes, and that's so like Milos
Mhm.
is so there's different constellation of symptoms that go into this particular mitochondrial disease diagnosis.
Yeah.
like Milas,
Right.
Kern-Sayer, or that's just that's like that's a mitochondrial myopathy. Um,
Yes.
but what Heather was talking about are like what's really challenging, are like with your son, with who did not fall into one of those
Yeah.
established, constellation of symptoms that's in the textbooks. And that's when it gets very challenging and so you might, you know, fatigue could be 1,000 different things, and if
Mhm.
that's all you have, maybe a little diarrhea or constipation or whatever, your mitochondrial disorder is like 42nd on the list of possibilities because there's just so many things above it. So that's just what makes some diseases are just so hard to diagnose
Yeah.
because of that fact. But yeah, you're right.
Right. But like this is now, and I'm biased because of our life experience, but now with your son, with fatigue and some of these other kind of common things that happen that you can explain away, and then with you and your stuff, like I do feel like when someone comes in and says, I'm just really tired all the time, or I can't tell you what it is, but something's not right. I'm not feeling like myself. I feel like more often than not, that doesn't get taken as seriously as it needs to.
Your point is very valid, though. Yes, it can be very frustrating, especially from the non-patient side, right? The non-physician side, to to
That's where
to,
I'm coming.
to
Yeah,
not
just
have
as
an explanation,
as a
right?
mom, as a patient,
And
as a
you, Heather,
whatever.
you felt that too, and you talked to that point, right? Like how challenging it was, and how frustrating it can be, even from as a
I
physician.
guess my point is, so what can we do about that? There's these mini fellowships. So this is a long roundabout way to just let Heather keep talking.
So, yes, I mean, for anyone who wants to learn more about mitochondrial disease, I will direct them to UMDF.org, which is the United Mitochondrial Disease Foundation. There's resources for doctors and for patients. And we have information about our mini fellowships as well. And we hope to expand this in the future.
That's great. Yeah, and that's umdf.org. People can find more
Correct.
information. And you mentioned there's a meeting. Where's that happening?
Yes, what is it called?
Yeah, it's called the MitoMed meeting. It's actually an amazing meeting because not only are there researchers and clinicians, but patients and families come. And there are times during the tracks where we're all interacting together. And it's really powerful because the patients and families get to vote on some of the research grants with the researchers in the room. And the researchers see the real world's impact of who
What?
they're
This
helping.
is
It's really
amazing.
powerful.
That's so cool.
Yeah.
Well, thank you so much for joining us, Heather. It's just and for sharing your story, and it's very impactful. And I'm actually going to go to this website, umdf.org. I want to learn more about this,
Yeah.
and I hope everybody listening does too. So, we really appreciate your time. Thanks again. Did you learn a lot about mitochondria?
So much. Well, not about mitochondria, but just the disease. Like it's
Right.
fascinating.
I did not verify whether or not the mitochondria is, in fact, the powerhouse of the cell. I think it is. I think it still is.
Still?
Do you remember that?
Yeah, I do. ATP.
Being taught that.
Uh-huh, I do.
That is the extent of what we are taught in med school as well.
That's disturbing.
No, I vaguely remember like hearing the terms like Milas and other things, but there's so much there.
Yeah.
And what a powerful story too. So
Yeah.
umdf.org. Go check it
Yeah,
out.
definitely
Learn about
go check
mitochondrial
that out.
disease.
Yeah, I think just professionally, even
Yeah.
it feels like, healthcare professionals should learn more about it.
Let us know what you thought of the episode. You can email us, knockknockhi@human-content.com. Visit us on our social media platforms. Hang out with us and our Human Content Podcast team. Instagram and TikTok at Human Content Pods. Always launching new stuff.
Yeah, lots of good stuff coming.
We got some great things.
Mm-hmm.
Like Medlines.
Mm-hmm.
Yeah, that's in the works.
Mm-hmm.
Learn about everything happening in medicine, in healthcare, in a very short time frame. Because who has time?
Who has time?
Who has time these days?
Are we supposed to be talking about this? I'm not even sure.
It has to happen now. We talked about it. All right. Thanks to our great listeners leaving feedback and reviews. Subscribe and comment on our YouTube channel at Gatcomb. Always try to take a look at those comments. We
They're
get
fun.
some content ideas from them too. People are like, oh, can
Yeah.
you talk about this and that? So please go over there and leave a
You
comment.
know what I appreciate? Sometimes social media comments are not so fun. You don't want to be in your comment section, but
Yes.
not true for this show and
Yeah.
its commenters.
You guys have been
Lovely
great.
comments.
I love it. Love seeing some repeat customers there too.
Yeah, that's fun.
People coming back. Full video episodes are up every week on that YouTube channel at Gatcomb. You can look at my beautiful face. I did not shower this morning. I think it's
Great.
obvious.
Hey.
I was in.
Is that what I smell?
You smell chlorine because I was
In the,
I was
you
in
were
the pool.
swimming
I
yesterday.
was swimming yesterday. We also have a Patreon. Go check that out. Lots of fun perks. By the way, we're revamping.
That's
Patreon.
right. We got a lot of fun stuff.
You got to check it out. It's where we have a community manager now.
Yes.
Who's just going to help us with just engagement and getting people excited,
Doing
and,
stuff.
and getting us to do stuff as well, and giving us ideas and things, and
Make it a really fun
yeah,
experience in
So
there.
please check it out. We also you always get the early ad-free episode access, interactive Q&A live streams, bonus episodes. We love doing those bonus episodes. We react to medical shows like The Pit and
Yes.
911, freaking Las Vegas or Minneapolis or wherever they have the 911 show.
I believe there will also perhaps be some additional Milo content, who is our blind
Yeah.
standard poodle with all sorts of eye issues who has the same exact hair as you do.
We
Just can't make
today
it up.
particularly, we look very similar.
Yep.
Patreon.com/Gatcomb, or go to Gatcomb to learn more. Patreon community perks. Let's shout out the Jonathans, shall we? Lucia C., Edward K., Marion W., Mr. Grandetti, Caitlin C., Brianna L., MP Cole, Tracy B., Mary H., Keith G., Parker, Muhammad L., David H., Kaylee A., Gabe, Gary M., Eric B., Marlene S., Scott M., Kelsey M., Dr. Hoover, Sean M., Ryan N., Jess K., Hawkeye M.D., Bubby Salt, and Shawnee D. A virtual head nod to you all. Patreon roulette time. Random shout out to Rebecca O. for being a patron. Rebecca O. Happy to have you. Thank you. Thank you for the support. And thank you all for listening. We're your hosts, Will and Kristen Flannery, also known as the Gatcomb. Executive producers are Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Burke. Editor and engineers Jason Portiz. Our music is by Omer Binsby. To learn about Knock Knock High's program, disclaimer, ethics, policy, submission, verification, licensing terms, HIPAA release terms, go to Gatcomb or reach out to us, knockknockhigh at human-content.com with questions, concerns, or fun medical puns. Knock Knock High is a human content production.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.